This is Chapter 16, and we're going to be reviewing pain management. Pain management is one of the most important assessments that you can do for your patient because pain can alter your patient's vital signs and other body systems. Pain is the most common reason that people seek healthcare, and it is often under-recognized, misunderstood, and inadequately treated. It's interesting because the patient is the only one who knows whether pain is present and what the experience is like. The patient's report of pain must be addressed and appropriately treated. Keep in mind that patients' cognitive impairments are special challenges to pain assessment and management, so you must be careful and observe the patient's behavior and nonverbal response to pain when he or she is unable to self-report. This would include the pediatric population. The two types of pain that you observe in patients are acute, which are transient, they come and go, and chronic, which is persistent. And this can include cancer and non-cancer pain. There's two ways of treating pain. The most effective pain management combines non-pharmacological and pharmacological strategies. Timely analgesic administration is important. This prevents the patient's pain from becoming too severe, which is crucial for optimal relief. Pain is easier to prevent than it is to treat, so keep that in mind. In most situations, administration of pharmacological agents around the clock rather than as needed basis is preferable. The American Pain Society and the American Association of Pain Medicine supports the around-the-clock administration of pain if pain is anticipated for the majority of the day. The current pharmacological approach to acute chronic pain management is to provide multimodal analgesia, which combines drugs with at least two different mechanisms of action so that the pain control can be optimized. Make every effort to include complementary or integrative methods, which generally do not require a healthcare provider's order. Complementary strategies provide an opportunity for a patient to assume an active role in achieving higher level of comfort and in some instances freedom from pain. Pain management should be patient-centered, with nurses practicing patient advocacy, patient empowerment, compassion, and respect. Caring for patients in pain requires recognition that pain can and should be relieved. Teaching your patient and his or her family about pain treatment and having an attitude of dignity and caring will allow you to individualize a patient's pain control plan. Pain is unique to each individual, and it is very important to recognize all factors influencing a patient's pain and integrate them to an individualized plan for pain management. A timely, factual, and accurate pain assessment requires you to work closely with patients and their families, be objective, listen carefully, and assess any symptoms that a patient expresses. Effective communication and caring are key to gathering all information needed to accurately determine the character of a patient's pain and its impact. Knowing these factors will help you intervene effectively to manage your patient's pain. So think about this. How can cultural and ethnicity affect pain assessment? Well, cultures vary in recognition of pain, expression of pain, when to seek treatment, and what treatments are desirable. For example, some cultures tend to be stoic, whereas others tend to be more expressive. Explore a patient's beliefs about pain, discomfort. For example, cultures with a holistic worldview of health and illness mix religious, spiritual, natural, and supernatural in their belief systems. Use interpreters to explain pain tools and help patients report their pain as needed. One of the most challenging conditions in pain management is chronic lower back pain. Results of a study on pain management for lower back pain include interdisciplinary Biopsychosocial rehabilitation interventions were more effective than usual care, and physical treatments in decreasing pain and disability in people with chronic lower back pain. For work outcomes, interdisciplinary rehabilitation seems to be more effective than physical treatment, but not more effective than usual care. A biopsychosocial approach to care is an individual centered model that considers the person, their health problem, and their social context. Biological refers to the physical or mental health condition. Psychological recognizes that person's psychological factors also influence functioning. Social recognizes the importance of the social contents. For example, work and family, pressures and constraints on functioning. The nurse cautions an elderly patient to limit her use of Tylenol. Why would the nurse make this statement to the patient? The correct answer is A. It is important to use non opioids cautiously. They may have more dangerous side effects than opioids themselves, especially for older adults. For example, acetaminophen and NSAIDs have some very serious side effects. Some of these include liver damage, gastrointestinal bleeding as well, even when given at recommended dosages. While caring for a 50-year-old Native American woman, the nurse asks about her pain level after a mastectomy. The patient seems hesitant to talk to the nurse and remains quiet. What action should the nurse take? The correct answer is D. Respecting cultural differences, the nurse should continue to try to engage the patient in conversation because it is important for the patient to report her pain level. Although the family can be of assistance when they are present, the nurse needs to assess the patient at the time she has contact with the patient and not make a series of phone calls. So it's important to understand that Native Americans may think that asking for pain medication is disrespectful to the nurse because it may imply that the nurse does not know what she is doing. In this care, therefore, it is important for the nurse to communicate clearly with the patient so that the patient does not hold back in expressing her pain for fear of being disrespectful. Safety is one of the most important things for our patients as nurses. So, monitor patients who receive opioids by any route for signs and symptoms of oversedation and respiratory depression. Excess sedation means that they are difficult to arouse and precedes respiratory depression, especially in opioid naive patients who are not chronically receiving opioid analgesics on a daily basis. Using a standard sedation scale can prevent respiratory depression by observing for and intervening for oversedation. Monitor your patient's activities such as standing, ambulation, transfer to a chair, things like that. If a patient has received an opioid, these are of the utmost importance. Assess your patient's blood pressure, pulse, and respirations before initiating activity. If a patient has undergone an outpatient procedure, educate patient and family caregiver about precautions. Patient cannot drive for 24 hours, and the caregiver may need to provide assistance with ambulation or take precautions to take home medications and make the environment safe. Monitor for potential side effects of opioid analgesics and recommend or institute supportive measures. An example of this would be a stool softener or high fiber diet for side effects of constipation. Another form of pain management would be an epidural analgesia, IV infusion. This would consist of a line and that should be carefully labeled and identified as such to prevent accidental connection with tubing of a different type. An example would be like a feeding tube or blood infusion line. Some of the guidelines to follow would be to limit access to epidural lines to healthcare providers with proper education and competence. There can be serious ramifications of misconnections, infections, occlusions, or misadministrations of medications. Trace an epidural catheter line from the access site to the patient's body, all the way to the end source of an infusion or capped access port before you connect or reconnect tubing or administer a medication. Communicate any practice changes, including dressing location, type of tubing, and connectors with all members of healthcare team who are providing care to the patient. Patients currently receiving opioids for chronic pain often require higher doses of analgesics to alleviate new or increased pain. This would indicate tolerance and not an early sign of addiction. Confer with healthcare provider who might not be aware of at-home dosages. Be aware of individualized doses and ensure that all caregivers are informed. Drug interactions, including enhanced or reduced effects or side effects, often occur with the multiple drug use required by people with chronic pain. This practice is termed rational polypharmacy or multimodal analgesia. Note agency policy for frequency of pain assessment and timing for follow-up assessments. The first 24 hours on opioids requires frequent assessment and at least every 4 hours. Accurate and factual pain assessment is necessary for determining a patient's response, arriving at proper nursing diagnoses, and selecting appropriate therapies. A comprehensive pain assessment helps you understand the impact of pain in a patient's life. Pain management requires you to work with a patient and family to prevent pain whenever possible and identify an acceptable intensity of pain and level of other factors, especially sleep, that allows maximum patient function. This process recognizes distinct and unique differences in patient perceptions and responses to pain. The nursing process guides you in learning to know a patient and develop an individualized plan of care. Assessment of a patient's pain cannot be delegated to a nursing assistive personnel. Nursing assistant personnel may screen patients for pain and provide selected non-pharmacological strategies. Some of these things include back rubs, heat, cold, elevation, as instructed by the nurse. The nurse directs NAP to eliminate environmental conditions that may aggravate pain. This would be an excessively warm, noisy room. They may also provide maximum rest periods. A written schedule for all to follow is ideal. Turn and place patients in a position of comfort at least every 2 hours, or remind patients to turn themselves. Encourage patients to use a pillow for splinting if needed. Observe for behavioral signs of pain in a patient who is unable to self-report. Ask patient to report pain using the pain intensity scale chosen by the patient and the nurse. Report in a timely manner any patient reports of pain intensity above a predetermined goal and nonverbal behaviors suggestive of pain. Screen the patient for pain during patient transfer or other activity that might provoke pain. Some of these pain medications may have adverse effects as a result from the pharmacological or non-pharmacological pain interventions. So it is important to record and report all of your findings as soon as possible. So in teaching, review patients' and families' understanding of the pain rating scale used and how to use it when providing pain therapies. Explain to patient and family about behavioral changes that may result from pain. Ask patient and family about fear of addiction, a common primary concern, or other misconceptions that could undermine the patient's pain relief. In the pediatric population, a numerical rating pain scale is valid measure for assessing a pain intensity in children with chronic pain. For children, the absolute value of pain intensity score is not as important as the changes in scores in each child. For example, if a child reports of pain of 2 and later you come in and the patient says it's 10, that is a very significant change. So that is what's most important. Also, keep in mind that some patients cannot use a numerical scale, so you may be using what we call the FACES scale. Some children are reluctant to report pain because they have a misconception about the cause of their pain or because they fear the consequences. One of these things would be maybe they would get another painful procedure or an injection. Infants and children experience pain but respond to it differently than adults. For example, they cry and they thrash about, have sleep disturbances, have shortened attention span, suck or rock, they refuse to eat or play, or are quiet and withdrawn. Variations in pain responses are related to the child's personality, developmental level, and previous pain experiences. Parents are helpful source of information when a child's pain is assessed and pain relief therapies are planned. Most parents know their child and how they exhibit their pain and which pain relief interventions have been successful. Children with verbal skills can rate their level of pain on the Wong Baker Faces Pain Rating Scale or the Outer Pain Scale. The older adults population have special considerations as well. Older adults who are able to express themselves can use a self reported pain scale. In addition, your assessment should include how the pain is affecting function, sleep, appetite, activity, mood, and relationships with others. Some older adults may require more time for you to explain the pain assessment scale that you select. Pain is not a natural occurrence of aging, although older adults are at risk for experiencing more pain producing conditions. Nonverbal older adults experiencing pain typically receive fewer analgesics than similar patients who are able to report their pain. Thus, be sure your patient assessment is thorough and evaluate a patient's response critically. For home care patients, consider home environment, such as the type of bed, do they have stairs, and environmental stimuli. When patients have a supportive bed and a quiet environment, these enhance sleep and promote pain management. Family caregivers are the main support for older people. Educate them about causes of pain conditions, common misconceptions about use of analgesics, type of pain medications appropriate for the patient, and how to support medication adherence. Patient controlled analgesia, or PCA, is an interactive method of pain management that permits a patient control over their pain through self administration of opioids. These will usually be morphine, hydromorphone, or fentanyl, with a minimal risk of overdose. It is a safe method of analgesic administration for acute and chronic pain, including conditions such as postoperative pain, cancer, and end of life pain. The goal is to maintain a constant plasma level of analgesic to avoid problems with PRN dosing. Systemic PCA traditionally involves an IV or subcutaneous drug administration. PCA devices are individually programmed to automatically deliver a specific healthcare provider prescribed continuous infusion, which is known as the basal rate of medication, a bolus dose, which is the patient initiated, or both. PCA prevents overdosing in two ways: by having control limits for the total dose that the patient can administer each hour, and having a time control or a lockout period that regulates the minimal interval. Sometimes this can be 10 minutes or 15 minutes in between doses. It is crucial that candidates for PCA be able to understand how, why, and when to self administer a medication dose. Oversedation is a risk in patients with sleep apnea and in obese patients with short, thick necks who commonly have undiagnosed sleep apnea. Assessment of the patient sedation levels is critical. So think about this. What do you think the advantages of a patient controlled analgesia would be? Well, more constant serum levels of an opioid and avoidance of peaks and troughs of large boluses. Better pain relief and fewer side effects from opioids because blood levels are maintained at a level of minimum effective analgesia concentration. Increased patient control and independence, and because PCA provides medication on demand, the total amount of opioid use can be reduced. Patient errors in PCA are often related to misunderstanding the system, mistaking the PCA button for a nurse call button, or letting family members operate the demand button. Incorrect programming is the most common type of error among healthcare providers. The task of administration of PCA cannot be delegated to the NAP, but the nurse can direct the NAP to notify the nurse if the patient complains of change in status, including unrelieved pain or oversedation to the nurse. Notify the nurse if the patient has questions about the PCA process or equipment. Never administer a PCA dose for the patient, and notify the nurse if anyone other than the patient is observed administering a dose for the patient. It is very important that you have an accurate recording of pain management, the drugs used, concentration, the time the pain medication was started, the amount of IV solution that was infused, and other things like that. Record regular assessments of the patient's responses on the PCA medication form, the nurse's notes, or on the pain assessment flow sheet, or on other documentation according to your institutional policies. A common misconception is that the patient can overdose on the PCA. Inform the patient and family that patient will not overdose with PCA if only the patient pushes the button. Explain the regimen to family so that they can support and help the patient, but not push the button for the patient. PCA is actually a very effective means of pain control in children who can understand the concept. When selecting children for PCA use, consider a patient's developmental level, cognitive level, and motor skills. Ordinarily, PCA use is safe and effective for patients as young as 5 years old. From a developmental perspective, use of PCA is particularly very effective in adolescents because it makes them feel like they are in control. Although controversial, some agencies have provided specific guidelines and training to allow parents and nurses to push the button for children that are too young or are unable to use the device on their own. When this is allowed, the concept of patient control is negated, and the inherent safety of PCA needs to be monitored. Pharmacological pain support is safe and effective in pediatric patients when dose is calibrated according to the child's weight. In older adults, some patients sometimes appear more sensitive to analgesics and experience more opioid side effects. Older adults have reduced renal and liver function, and therefore this slows down the metabolism and excretion of opioids. This leads to a faster peak effect and a longer duration of action of the opioid. Dosages should be started low and titrated upward slowly until the pain relief is achieved. If a patient confusion occurs while the PCA is used, call to get orders to lower the dosage, lengthen the lockout, or to add a non-opioid analgesic to reduce the opioid dose. Nurse activated around-the-clock dosing is another alternative, and refusing to medicate is not the answer. confusion may be caused by pain rather than by the medications. So, in relation to pain management, what activity can the nurse delegate to the NAP? The correct answer is B. The nurse is always responsible for the initial pain assessment and administration of medications. The pain scale cannot be changed by the NAP. However, the NAP can assess the patient using the same scale that was decided upon by the nurse and the patient. Turning and positioning the patient as ordered can be delegated to the NAP. The nurse will instruct the NAP as the time frame for repositioning and will instruct the NAP to report to the nurse immediately any issues. Epidural analgesia is an effective mode of pain relief during labor and does not result in any adverse effects or increased frequency of cesarean delivery. Patient-controlled epidural analgesia, or PCEA, has been shown to provide excellent control of labor and post-operative pain when compared with intravenous patient-controlled analgesia. Epidural opioids reduce the total amount of opioid medication required to control pain and thus produce fewer opioid-related side effects. Safe and effective management requires a coordinated interprofessional approach. The epidural space is a potential space that contains a network of vessels, nerves, and fat. It is located between the vertebral column and the dura mater, the outermost meninges covering the spinal cord. Analgesic is distributed by diffusion through the dura mater into the cerebral spinal fluid, by blood vessels in the epidural space, or by the systemic delivery, or it may be absorbed by fat in the epidural space. Analgesics acts by binding to opiate receptors in the dorsal horn of the spinal column, thus blocking transmission of the pain impulse to the cerebral cortex. Opioids and local anesthetics separately or in combination are used into the epidural analgesia. Opioids are delivered close to their site of action and thus require much smaller doses to achieve the same pain relief. Common opioids given epidurally include morphine, hydromorphone, and fentanyl, and sufentanil. These opioids differ by their lipoprophylactic or fat-loving and hydrophilic or water-loving properties, which affect absorption rate and duration of action. An anesthesia provider places a catheter into the epidural space below the second lumbar vertebra, where the spinal cord ends. Epidurals may also be placed into the thoracic level of the spinal cord. Temporary or short-term catheters are not sutured in place and exit from the insertion site in the back. A catheter intended for permanent or long-term use is tunneled subcutaneously and exits out of the side of the patient body or into the abdomen. Tunneling reduces infection and catheter dislodgement. A sterile occlusive dressing covers the catheter exit side and is secured to the patient. An X-ray film confirms the epidural catheter placement. A healthcare provider administers epidural medication intermittently via a bolus injection, or a patient can inject on demand using a pump. An epidural infusion can also be given continuously via a controlled delivery system, such as an implanted infusion pump. The use of epidural opioids requires astute nursing observation and care. The catheter poses a threat to patient safety because of its anatomic location. It is potential for migration through the dura and its proximity to the spinal nerves and vessels. Catheter migration into the subarachnoid space can produce dangerously high medication levels. Frequent complications include hypotension, respiratory depression, motor block, urinary retention, pruritus, and superficial infection around the catheter. Do not administer or other supplemental opioids or sedatives when patients are on an epidural. The combined effect may cause respiratory depression. In many healthcare agencies, anesthesiologists and nurse anesthetists are the only healthcare providers who may initiate epidural, opioid infusions, or administer a medication bolus. The skill of epidural analgesia administration cannot be delegated to nursing assistive personnel. The nurse can direct the NAP to observe the dressing over the insertion site when repositioning or ambulating patients to prevent catheter disruption. Avoid pulling patient up in bed while he or she is laying flat on the back, which can dislodge the epidural catheter. Report any catheter disconnection or leakage from dressing immediately. Immediately report to the nurse any change in patient status, comfort level, or loss of sensation or movement to the nurse. Record drug dose, method of administration. This is whether it was a bolus, on demand, or continuous, and the time the medication was given. With continuous or on demand infusion, obtain and record pump readout hourly for the first 24 hours after infusion begins, and then every 4 hours. Review the pump settings and usage together with the staff that is oncoming for the next shift. Record regular periodic assessments of the patient's status in the nurse's notes and electronic health record, and or on appropriate flow sheet, including their vital signs, pulse oximetry, capnography, intake and output, sedation level, pain severity score, neurological status, appearance of epidural sites, presence or absence of adverse reactions to medication, and presence or absence of complications resulting from placement and maintenance of the epidural catheter. Report any adverse reactions or complications to healthcare provider immediately, and document evaluation of patient learning. When teaching a patient, describe the catheter placement and the use of patient and use to the patient as appropriate. By drawing or showing pictures often helps. Teach patient and family members the purpose and action of opioid or local anesthetic, as well as signs and symptoms of adverse reactions. Teach when and which signs and symptoms should be reported to the nurse. Teach the patient to report pain level with an acceptable to the patient pain scale. Inform patient of other pain management strategies that supplement or enhance pharmacological interventions. Some patients may attempt to ambulate without assistance or may overdo the other activities. Caution them to begin slowly to avoid any type of injury, and to always call for the nurse to assist with any activity. Explain that the first attempt to ambulate may feel strange, secondary to decreased sensation, but motor function should be unaffected. In the pediatric population, apply the EMLA cream, which numbs their site of insertion, for a minimum of 60 minutes before the catheter is inserted. Dosing regimens for children must be adopted for age and weight with a maximum dosage clearly defined to minimize cumulative local anesthetic toxicity. Hourly assessments are recommended, especially in the first 12 hours for children. There should be a regular review of need for infusion, especially after 48 hours. In the elderly population, the older adults are at the same risk for complications and medication adverse effects as the other adult patients. Patients in home care. Patients needing long-term therapy are discharged with a tunneled catheter. Before considering catheter placement and care in the home, assess patients' fine motor skills, cognitive ability, and stage of disease and prognosis, as well as the degree of involvement of family caregiver. Teach the patient and caregiver proper dosage and administration of medication. Evaluating patient's technique for catheter care, administering medication, and reinforcing instructions are priorities. Teach patient and caregiver aseptic techniques for medication administration as needed and for all catheter care procedures, including dressing changes. Instruct the patient to change dressing every week. The policy may vary with home care agencies, so keep that in mind. Teach signs and symptoms of infection and instruct patient to report to nurse or healthcare provider immediately should any signs and symptoms appear. Teach the patient and caregiver about signs and symptoms of the adverse reaction to medications that are being used and interventions to alleviate mild side effects in the home. Give patient and family phone numbers of the healthcare providers to contact in an emergency and information on resources inside of their community. Local anesthetic infusion pump for analgesia. During surgery, mainly for joint replacements, some surgeons insert a one-way catheter into the surgical site and attach it to an infusion pump. The pump delivers local anesthetic directly into the wound bed and constantly bathe the specific nerve or nerve plexus responsible for pain at the surgical site, thus maintaining analgesia during and after surgery. Even if the patient still requires oral analgesics, the total dosage of medication is often reduced. The pump has a demand rate, 4 to 6 ml bolus, and a continuous or basal rate that can be from 2 to 4 mLs an hour. Continuous flow reservoirs hold about 100 mLs, whereas patient controlled units have a 60 ml reservoir. The device remains in place for about 48 hours and is rarely removed during hospitalization. Patients learn how to remove the catheter and take it out at home. Patients regain their mobility quickly, thus reducing the risk of developing post-surgical complications. Nursing care focuses on the assessment of catheter, site, and connections, evaluating the local anesthetic side effects, and patient teaching. The skill of managing local anesthetic infusion pump analgesia cannot be delegated to the nursing assistive personnel, but they can help you pay close attention to the insertion site when providing care to avoid dislocation. Report if the dressing becomes moist, report any catheter disconnections immediately, and notify the nurse if a change in patient status or a level of comfort. So, just in review, everything that we do must be recorded. So, record drug concentration, the date the catheter was inserted, and type of demand feature. These are very important for your patient record. Record the location of the catheter, patient's pain rating, response to the analgesia, and additional comfort measures that are used by the nurses to help alleviate the pain. You must also record any additional analgesics that were necessary to control the pain. Record any adverse reactions to the local anesthetic. Report any damp dressing or displacement of the catheter to the surgeon. When teaching, it's important to provide preoperative teaching because the device will be placed in the operating room during the surgery. If the device is on demand, instruct the patient to depress the button every 6 hours. Instruct the patient to inform the nurse if pain exceeds pain intensity goal because additional oral or intravenous analgesics are available for breakthrough pain. In the pediatric population, local continuous infusion pumps have been used for children undergoing orthopedic surgery. So, it is important to include parents in your education and instruct the parents and the child as described under home care considerations. Explain special precautions that can help to avoid dislodgement of the catheter, especially since pediatric patients are so active. With older adults, continuous dosing is sometimes administered, but demand doses require a mentally competent adult. In addition, special precautions can be taken to protect the catheter. Home care. So instruct the patient to notify healthcare provider if excessive fluid or bleeding under dressing occurs. If the patient has signs of analgesic reaction, including arrhythmias, weakness, or numbness of the affected area, seizure, confusion, drowsiness, ringing in the ears, or if signs of infection develop. Provide a written copy of the instructions. Provide verbal and written instructions regarding on how and when to discontinue the device when at home. Remind patient to place catheter in a plastic bag and bring it to the first visit following up their surgery. Provide instructions regarding extremity movement. And home health nurse may be ordered to remove pump via surgeon's order. Non-pharmacological pain management is a very useful tool for nurses. Some of these non-pharmacological pain management interventions are also classified as complementary or alternative therapies, and evidence supports pain relief. Distraction, relaxation, guided imagery, and cutaneous stimulation, such as massage and acupuncture, are a few examples of effective non pharmacological measures. Many non pharmacological techniques trigger a relaxation response by stimulating the parasympathetic nervous system because pain often causes muscle tension and anxiety. PNS stimulation relieves these disturbing responses. Non pharmacological interventions are appropriate for patients who find such interventions appealing, express anxiety or fear. They may benefit from avoiding or reducing drug therapy and have incomplete pain relief with pharmacological interventions alone. Relaxation. A patient's full participation and cooperation are necessary for relaxation techniques to be effective. These techniques are particularly useful for chronic pain, labor pain, and relief of procedure related pain. Relaxation interventions involve progressive muscle relaxation, massage, quiet breathing, deep breathing, guided imagery, or a combination of all. Guided imagery. The goal of guided imagery is to have a patient use one of several of the senses to create an image of a desired result. Focusing on the imagination helps patients change their perceptions about their disease, treatment, and healing ability, which helps to relieve pain, tension, or stress. Relaxation. A patient's full participation and cooperation are necessary for relaxation techniques to be effective. These techniques are particularly useful for chronic pain, labor pain, and relief of procedure related pain. Relaxation interventions involve progressive muscle relaxation, massage, quiet breathing, deep breathing, guided imagery, or a combination. Guided imagery. The goal of guided imagery is to have a patient use one of the several senses to create an image of desired result. Focusing the imagination helps patients change their perceptions about their disease, treatment, and healing ability, which helps to relieve their pain, tension, or stress. Massage blocks the perception of pain impulses and helps relax muscles, tension, and spasm that otherwise might increase the pain. Hastens the elimination of waste stored in muscles, improves oxygenation of tissues, and stimulates the relaxation response in the nervous system. Massage after a bath or before a patient prepares for sleep promotes relaxation and comfort. Do not perform massage over a bruised, swollen, or inflamed area or on bones of the spine. Heat and cold can be used. The selection of heat versus cold varies on a patient's preference and condition. Application of heat or cold in healthcare agency or a home health environment requires a healthcare provider's order. Although physiological responses to heat and cold differ, superficial heat or cold applications provide comfort in similar conditions such as muscle spasms, strains, and localized joint pain. Distraction. There are internal and external distraction techniques. Internal techniques include having patients count, sing to themselves, pray, or repeat statements in their head, such as, I can cope. External distractions include changing a patient's activity. Provide them with needlework, listening to music, reading, walking, playing a musical instrument, or watching a comedy program. When the distraction is removed, the patient may be having a heightened awareness of pain. Assessment of the patient's pain cannot be delegated to the nursing assistant personnel. The skill of non pharmacological pain management strategies can be delegated. The nurse should direct the NAP to identify and explain which non pharmacological measures work best for the patient. Identify the need to adapt strategies to patient restrictions and report worsening of the patient's pain. Record in the nurse's notes the electronic health record or chart, the assessment findings, procedure and techniques used, the preparation that was given to the patient, patient's response to the procedure or technique, change in overall condition, and further comfort needs related to the event, and incorporate your pain relief techniques in the nursing care plan. Report the patient's response and non-pharmacological interventions to the staff at the change of shift or in care plan meeting. Report any unusual responses to the techniques, such as uncontrolled or aggravated pain, muscle spasms, and other things like that. The nurse in charge should be aware of these responses, and sometimes you must also notify the healthcare provider. Special considerations. When teaching, provide the patient information about each non pharmacological therapy, including the purpose, the rationale for how pain is relieved, and how the patient can maximize its benefits. If the NAP performs massage, you still need to provide the patient the education. Some techniques require more practice before patients can achieve any results, and it's important for them to know this. Pharmacological intervention is sometimes required to lessen the pain so the patient can relax. Teach patient to rest between periods of activity at home and in hospital because fatigue increases the pain perception. Teach family members how to perform massage, if it isn't contraindicated, as part of their home care. For pediatric patients, you can use non pharmacological pain management therapy successfully with children. Adapt distraction and relaxation strategies to the developmental level of the child. For example, use a pacifier for an infant, or offer to read or play a recording of the favorite story for a preschooler. Encourage a teenager to listen to music on some headphones. Play therapies are usually available at large pediatric hospitals and are good resources for appropriate distraction techniques. Because children usually have an active imagination, relaxation is often a powerful adjunctive to pain control. And parents are very helpful in providing pain relief. For example, they provide comfort by their presence or conversation and by holding and cuddling their child. In the older adult population, visual and hearing cognitive and motor impairments may make it difficult for older adults to be able to effectively use procedures such as distraction, relaxation, or guided imagery. Make certain that glasses, hearing aids, and other assistive devices are in place. An evidence-based practice protocol for pain management in older adults recommends these guidelines for non-pharmacological therapies. Tailor non-pharmacological techniques to the individual. Cognitive behavior strategies may not be appropriate for the cognitively impaired. Physical pain relief strategies focus on promoting comfort and alternating physiological response to pain and are generally safe and effective. Patients that are in home care, family members need to collaborate on planning time to reduce noise and other stimuli in the home to promote patient relaxation techniques.